depression, where when you give even just about 0.5 milligrams per kg body weight over 40 minutes infusion, it can produce an antidepressive effect for nearly about 10 to 12 days. This can be repeated, every 3 or 4 days. The patient can have very good relief from depression. It can have a prolonged antidepressive effect. So these are some of the newer, uses of ketamine. And especially some acute severe pain, when you give ketamine infusion, they get very good relief. That has been, that is the reason why many of these pain specialists are extremely fond of ketamine nowadays. So these are the additional things which we should know about, but it all depends on how you use it. Any drug depends on how you use it. It all depends on the person who uses it. What is his knowledge about that drug? That is the most important thing. That's what, when I was in armed forces, we were told that the man behind the machine is more important than the machine itself. You should know how to use the machine or the gun. Then you know how to use it, as for an advantage. So like that, the drugs are also like that. So a sound knowledge of the drug, you can really manipulate, you can create wonders with the drug, isn't it? So that is why all these things in detail we are discussing about these IV induction agents, later inhalation induction agents, the pharmacokinetics, pharmacodynamics, their physical properties, all are very important, a sound knowledge, so that you can be very safe and you can use it for the benefit of the patients. Okay, with this introduction and regarding yesterday's, we'll go into today's discussion regarding two other, we can use them for induction, definitely, IV induction agents, or majority of the times these two drugs are used mainly for sedation, and they are used for pre-medicants or IV sedation in the intraoperative period or even the postoperative period or in the ICUs. And for procedural sedation, they are also used for awake craniotomies. Dexmedetomidine is very popular for awake craniotomies and for procedural sedation in endoscopy rooms. These drugs are widely used, both Midazolam and Dexmedetomidine. So today we'll discuss about these Midazolam and Dexmedetomidine. Invariably, they are kept for you in the afternoon viva. So on the viva table, these two drugs are always there, and many of the examiners are quite fond of asking questions regarding these drugs. So let us talk about the Midazolam first and later Dexmedetomidine. So Harini and Geeta are ready, and they must have read a lot regarding these two drugs. We'll see how much they know, and we'll have probably some good discussion regarding these two drugs. Okay, let us discuss about Midazolam. So, okay, what kind of what group of drugs Midazolam belongs to?
It is benzodiazepines, short-acting benzodiazepines.
Yeah, it's a benzodiazepine drug. And how do you classify benzodiazepines?
Imidazole ring containing.
No. How do you, I mean, not based on the structure, based on their duration of action. It becomes easy for
short-acting, intermediate, and long-acting.
Is there any ultra short-acting benzodiazepine also? Is there any ultra short-acting opioid? Ultra short-acting opioid.
Remifentanil.
Remifentanil. Like that, you do have any ultra short-acting,
benzodiazepine?
Remimezolam. Remimezolam, it's recently been introduced and it is not available in India, of course. Yeah. It is again an ultra short-acting benzodiazepine. So its duration of action is only 3 to 6 minutes. It has to be given as an infusion, like remifentanil. And like remifentanil, it gets metabolized with the tissue esterases. So rapidly it gets metabolized. Once you stop, the effect also will not be there after, say, 5-10 minutes. The effect will not be there. So that's how you can have a total control of the drug when you're using as an infusion. So you may have to use Remimezolam as a infusion. So of course, so that is ultra short acting benzodiazepine. Short acting benzodiazepine, as you said, is midazolam. Intermediate acting benzodiazepine is, give example.
Lorazepam.
Alprazolam,
Lorazepam.
lorazepam, then tamazepam.
Atamazepam.
Yeah, alprazolam is orally given. It is not available
Yes, sir.
in injectable form.
IV.
Whereas lorazepam and tamazepam are available as
IV form.
they are also available as oral form as well. And the long-acting benzodiazepine is
Clonazepam. Diazepam.
diazepam, mainly the diazepam. Of course, clonazepam is it has got other uses. Diazepam is a sedative, isn't it? So diazepam is long-acting. So this you should always know. And because the ultra short-acting benzodiazepine, ramiprozole is not available, so the short-acting benzodiazepine, midazolam, is the most commonly used drug. I think almost every day you are using.
Yes, sir.
Most of the patients you are using, especially when you want to give general anesthesia. It is one of the most commonly used pre-medicant or pre-induction drug. Sometimes you call it pre-induction drug. Of course, the diazepam or the other drug, what you said, the Restil, what we alprazolam. That is, many times alprazolam is used in the previous night.
Medication.
It is intermediate acting, so it is usually given as a pre-medicant on the previous night for patients to reduce anxiety. Okay, coming to midazolam. So can you start with the midazolam? Is it available as an ampule form or an vial form?
Available in a vial form, sir. And
Is it also available in the ampule form?
Yes, the preservative-free is available in the ampule form.
Even your regular midazolam also doesn't have any preservative. It has some amount of alcohol. You do not consider it as a preservative. So usually midazolam in the vial form, what is the strength it is available?
1 mg, 2 mg, and 5 mg per ml dose is available.
And how about in ampule form?
2 mg.
Available as 5 milligram per ml. In ampules, it is available as 5 milligrams per ml, whereas in vials, it is available as 1 milligram, 2 milligram per ml, and also 5 milligram per ml. So I think Geeta and Harini, we have lost you. Or there is a problem with my this thing.
5 grams.
So there's some lag, sir. There's some.
Their picture is also not moving.
Wait, sir.
Mahal?
Sir, can you hear us, sir?
No, your net is not proper.
Net is not good. So picture is also not moving. I'm not able to hear you properly. It has become still. Are you able to hear me, Harini and Geeta? Well, they are using which particular net there?
Sir, I think they are using from their local network, sir.
So, now can you hear us, sir?
Yeah, now I'm able to hear you. So, okay, that invariably, we always ask you about the strength of these is you can have an ampule on your table or you can have a vial on your table. 10 ml vials are usually there. 5 ml vials are also available and 10 mls are available. So, because, another very important thing is here is why should you know about the strength is because, you have to give in that liquid form only, and you have to know what is the strength, how much do you have to give, because you calculate based on so many micrograms per kg body weight or milligram per kg body weight. Finally, you have to give in a liquid form only. So for that, you have to know what is the strength of these drugs that is available. Okay, so
Yes,
other important thing is what is the pH of this midazolam that is available?
3.5, sir.
Yeah, 3.5. So it has got an acidic pH. So why it has that acidic pH is there.
So when it is less than 4, it is water soluble, sir.
Yes,
So
very good.
that is why they maintain that pH.
Yeah, so it has been made hydrophilic, water soluble, by converting into an acidic solution. So that is why the pH is 3.5. So once it is introduced, what will happen into the blood?
So when physiological pH, it becomes a lipophilic,
Lipophilic.
highly lipophilic. Yes.
It becomes transformation, structural transformation occurs, and it becomes highly lipophilic. So otherwise, other benzodiazepines like diazepam is there. So their pH is much higher and they are lipophilic, isn't it? So what is the preservative used with diazepam? Yesterday we were discussing about that. With diazepam, what is the preservative that is? It's quite painful. You cannot use diazepam intramuscularly. You have to use IV.
Yes, sir.
If IV produces a lot of irritation and pain. It is propylene glycol.
Yes, sir. Propylene glycol.
Propylene glycol. Yesterday we were discussing about etomidate. Etomidate, originally it was introduced along with the propylene glycol. Now etomidate is a lipid emulsion preparation. So that's why, propylene glycol was
Yes.
removed from etomidate and other preservative has been used. Diazepam has got this problem. It has got
Yes.
the propylene glycol. Whereas midazolam, it doesn't have any preservative one. Second thing is its pH has been reduced to 3.5 so that it is more water soluble, and when you inject, it's not much of pain, but because of its acidic nature, it may produce slight irritation to the inner wall of the veins. Some people do have some irritant pain can be there with midazolam also. But majority of the times you don't give it directly, you dilute it and then give. So there is not much of a irritation with midazolam. So these are some of the important physical properties of midazolam. Now the thing is the mechanism of action of benzodiazepine. So where does these drugs act?
The GABA potentiated, sir.
So just like
Acts on the GABA A receptors.
all these are
GABA A receptor potentiator.
Yeah, they all act on the GABA receptors, just like propofol, etomidate,
Yes, sir.
diapentone sodium barbiturate
GABA A.
produces its
Yes,
effect
sir.
on GABA receptors. So
GABA.
now coming
Yes.
to the effect of midazolam or benzodiazepines on CNS.
Yes, sir. Sir, in CNS, it causes sedation, anxiolysis, and
Okay,
hypnosis, sir. And it causes anterograde amnesia.
anterograde amnesia.
Yes.
That is
Yes,
one
sir.
of the most anxiolysis, sedation. Okay, then hypnosis is higher dose. That is, hypnosis means induction of anesthesia, and also produces has got an anticonvulsant effect and anterograde amnesia. It is extensively used also as anticonvulsant by non-anesthesiologists. We don't use it as an anticonvulsant because we have other drugs like thapentone, propofol, and all those things.
Yes,
More potent drugs are there.
and it reduces the cerebral metabolic oxygen
No,
requirement.
one more thing I just want to ask you is about anterograde amnesia. What do you mean by anterograde amnesia?
Yeah.
What is anterograde
So,
amnesia?
so they will have the till the time we administer the drug, whatever memory they have will be intact, but new memories will be erased, sir. So they won't know what happens after we administer the drug.
Okay, anterograde is after the administration of the drug
After
and till it
the-
is effective. So till then, whatever that is occurring, the patients may not remember, isn't it? So that is how, is it an advantage or a disadvantage?
So it's an
Anterograde.
advantage, sir. So in case the patient won't remember what happens after we administer the drugs, most of the time. They won't
Yeah.
Helps to
remember.
reduce their anxiety when the patient is in the operation
No,
theater.
anxiolysis is different. Anxiolysis is different. Don't get confused with anxiolysis and anterograde amnesia. All anxiolytic drugs have to produce anterograde amnesia. That is typical with benzodiazepines. They only
Yes,
produce
sir.
anterograde amnesia. So, because surgery and whatever occurs
The
inside
traumatic experience.
you, they are not good memories to be carried throughout your life. It is not
Yes, sir.
one's marriage or such things you remember throughout your life, but not your stay in the OT and in the ICU in the post-operative period. So that's how that is a very good advantage. They produce very good anterograde amnesia. Have you heard about retrograde amnesia also?
Yes,
Yes,
sir.
sir.
What is this retrograde amnesia?
So
So
the
the memory-
recent memories just before administering the drugs, they will
That
tend to
gets
forget,
lost.
sir.
Need not be administering the drug. So actually,
Just before.
this retrograde amnesia.
Yes, sir.
It is always the majority of the times it's a traumatic.
Yes, sir. It's a trauma experience.
Traumatic brain injury, head injuries. Just before what had happened, actually, many of these patients will not remember. That's the retrograde amnesia. So you should always remember differences between retrograde amnesia and retrograde amnesia. There was some movie in Tamil, I think, and then Surya's movie.
Yes, sir. Yes, sir. Gajini.
Short memory or
The
retrograde,
short memory.
isn't it?
Yes, sir.
So
Yes, sir.
Amir Khan also did, I think, in Hindi.
Yes, sir. Gajini.
So that is retrograde amnesia. So anterograde amnesia is after the drug has been introduced. So that is another very important thing. So the anxiolysis, sedation, anticonvulsant effect, hypnotic effect, and anterograde amnesia. All these are the very important CNS effects. Plus major, this thing I was asking you is about their effect on cerebral blood flow, CMRO2, ICP. What is the effect of midazolam on these things?
So it reduces the cerebral blood flow, sir. And it
CMRO2?
also reduces the CMRO2 also.
Yeah, naturally, it has to reduce the CMRO2. So all drugs which produces sedation except ketamine. Ketamine is a drug, though it produces quite a bit of sedation, it increases the CMRO because of its sympathomimetic effect, whereas midazolam definitely reduces CBF and in CMRO2 also is reduced. ICP?
It does not have much effect on the ICP.
Marginally decreases ICP. May not have effect.
Significantly.
But because it is reducing CBF, may decrease marginally. But does these drugs have a limitation or of their effect on the CNS? By their dose, if you keep increasing the dose, the effect also keeps
It
increasing.
has ceiling effect, sir. Yes, it has ceiling effect for
Limitation
yes,
or a ceiling effect is there, isn't it?
Yes, sir.
EEG, as well as, they may not produce burst suppression.
Yes, sir.
Like barbiturates, propofol, Gurudatt and all. They'll not produce a flattening of the EEG and they don't produce burst suppression because of the ceiling effect is benzodiazepine. That is another important thing you should always remember about. And they also produce hypnosis, as already discussed. Okay, that's about the effect of midazolam on the CNS. Then the CVS.
Increases the heart rate and it reduces the systemic vascular resistance. The cardiac output is maintained overall. So
Heart rate may not be, they are actually cardiostable drugs.
Yes, sir.
Benzodiazepines are supposed to be very good cardio stability they have. Though in high doses or when they are given rapidly, they may reduce systemic vascular resistance. They may produce slight hypotension, but otherwise they are very good, cardio stable drugs. They do not have much effect on the heart rate and myocardial contractility or on systemic vascular resistance. Slight decrease in systemic vascular resistance occurs and no effect on the pulmonary vascular resistance. So, and they don't have arrhythmogenic effect also. They don't produce arrhythmias like, other agents like, ketamine can produce arrhythmia, but this will not produce any arrhythmias. So, okay. So about its the effect on respiratory system.
It causes dose dependent ventilatory depression, sir.
Very good.
And tidal volume reduces and increase in the respiratory rate.
Great. More reduction in the tidal volume rather than on the respiratory rate. So respiratory rate increases, but the tidal volume decreases. So
Decrease.
dose-dependent respiratory center depression will occur. That is one of the
Yes, sir.
problems. So when you give it rapidly or when you give over higher dose, they may produce respiratory depression.
Apnea.
Depression.
The extent of apnea they can produce.
Yes, sir.
So that is how, with the therapeutic concentration, what we use, or therapeutic dose, what we use, the effect on the respiratory center is not much. With what we use as a pre-medicant, the patients will not have much problem, or even procedural sedation when we are using, it won't have much effect. What about its effect on the airway reflexes?
Reduces the. No, it
They
is.
inhibit the airway reflexes.
Yes, sir.
They inhibit the airway reflexes, but they don't sensitize the airway reflexes like tabent. But they are going to depress the airway reflexes. So another good property of benzodiazepines. And older patients, you have to be cautious because airway reflexes are obtunded, and these patients, as such, they'll have a obtunded airway reflexes. Aspiration problem is always there in older people. So you have to be careful when you're using benzodiazepines in the older patients, especially the parenteral benzodiazepines.
Yes.
Okay. So then on the bronchodilation, do they have any bronchodilatory effect?
Oh, no, sir. No.
They don't have any
They don't have any
bronchodilatory effect. No constriction or bronchodilatory effect. Okay. Do they cross the placental barrier? Benzodiazepine?
Yes, sir.
Yes,
They
they cross the placental barrier. So,
yes, sir.
Can we use it for labor analgesia along with other analgesic drugs? What is the problem when they cross the placenta? What is the effect on the neonate when it is born?
It causes floppy baby syndrome, sir.
Yeah, flappy infant syndrome. That
Yes,
can occur. It can produce, severe hypotonia of the muscles of the baby. Plus, it may produce respiratory depression. So you should be cautious when you're using benzodiazepines along with other analgesics during labor. So because they can produce flappy infant.
Yes, sir.
Why this muscle, effect on the muscles, skeletal muscles? What is the effect?
Because muscle relaxation, sir.
Yeah,
Because
they produce central muscle relaxation.
because muscle relaxation.
Yes.
Yes, sir.
Effect on the spinal.
Yes, sir.
Their effect on the
Yes, sir.
spinal cord, they produce central muscle relaxation. Unlike the muscle relaxants, what we use, skeletal muscle relaxants like depolarizing and non-depolarizing muscle relaxants, they produce peripheral muscle relaxation, isn't it? Benzodiazepines produce central muscle relaxation. So that is the difference between these muscle relaxation effect with benzodiazepines compared to the depolarizing and non-depolarizing muscle relaxants. Okay, now with these pharmacodynamic effects, what is the pharmacokinetics? It gets metabolized.
So it gets metabolized in the liver. Yes, sir. In the liver, sir.
Glucuronidation conjugated conjugated by to
Pardon?
It gets conjugated in the liver, sir, to midazolam glucuronide.
Always, phase 1 metabolism is more important with these drugs, especially midazolam. Then phase 2. Phase 1 is actually 4-hydroxymethyl midazolam. And 1-hydroxy midazolam. These are the metabolites, 1-hydroxy midazolam and 4-hydroxy midazolam. So why should you know about these metabolites? Do they have
So
any?
the
Because the
one
metabolite-
hydroxymidazolam, it has half the potency of midazolam drug. So in case
Not
of
half,
renal
20%.
impaired in CKD patients, when you're giving
DCLD.
midazolam and DCLD patients, the
Have a
duration
prolonged-
of action will be for a longer duration for in the case of giving midazolam.
So it's about 20%.
Yes, sir.
The effect is about 20% with these metabolites. So that is why you should know about these metabolites. Okay, now where all we use Midazolam and in what routes of administration we can use? Can we use
As a
the
pre-medical.
oral Midazolam?
Yes,
sir.
sir.
We can.
It comes as a syrup, sir. 2 mg per
Syrup
ml syrup,
also.
sir.
What
Syrup
is the
formulation.
strength of the syrup?
2 mg per ml, sir.
2 mg per ml, 1 mg per ml is also available. It's especially for pediatric use, isn't it?
Mm.
So
Yes.
what is the bioavailability of oral Midazolam?
50%,
50%,
sir.
sir.
Yeah, 50%. Bioavailability is quite high, but there is a wide range, 15 to 50% bioavailability is there. So what is the dose that we can use it in pediatrics oral Midazolam?
0.25 mg per kg, sir.
You can go for 0.1 to 0.5 milligram per kg body weight.
Okay, sir.
So you should remember, the IV Midazolam is 0.01 to 0.05 milligram per kg.
Yes, sir.
For oral, you remove that 0. It is
Okay.
0.1
to 0.1.
per kg body weight for oral dose. Okay,
Mhm.
so you can give it orally, you can give intramuscularly also.
Yes,
Yes, sir.
yes.
So the dose is, what is the intramuscular dose?
0.07 to 0.08 mg per kg per
Go
minute.
up to 0.1 milligram per kg body weight intramuscular.
Yes, sir.
Okay. Transnasally, can it be used through the nasal route? Nasal spray, is there available? Midazolam nasal spray.
So, I'm not sure, sir, because we never used it before, sir.
No, it
But
is-
we only heard of it, sir.
For children who are brought with convulsions. So you can just put it in the nostril of the child, give 2-3 sprays or 2-3 puffs of nasal spray. So it gets absorbed quite rapidly, almost 50 to 60% bioavailability is there with the nasal spray. And it comes as 5 milligram per ml nasal spray.
Okay,
So
sir.
nasal spray, you can go for 50-meter doses are there.
Okay.
One dose can give about 100 micrograms. So it has been used even for pre-medication in children because you may not have IV
Access.
and oral, it may take time. So nasal spray, it is 10 minutes. Within 10 minutes, it starts acting. So you can use nasal spray. That may also be kept for you in the afternoon discussion. Sometimes nasal spray, in some of the examination centers, I have seen that is being kept. So it is better to know about nasal spray also. It is available and it is one of the routes that can be used, Midazolam. Okay, coming to medication dose for pre-medication or
So, pre-medication,
Point.
just now I told you
0.05 to 0.1.
0.01 to
0.01 to 0.05 mg per
majority
kg.
of times we give about 1 milligram.
Yes, sir.
So roughly between 0.01 to 0.02 milligram per kg body weight, we'll be
Yes.
using Midazolam. So what is the advantage of giving Midazolam as a pre-medicant?
It causes anxiolysis.
Anxiolysis.
No, anxiolysis just before induction, what is the use of producing anxiolysis? The previous night you would have given some benzodiazepine.
Requirement of opioid reduces on giving midazolam. So,
Is it reduction of
fentanyl
anesthetic
require
agents?
Reduction of anesthetic
anesthetic
agents,
agents.
volatile anesthetic.
anesthetic.
Improves the depth of anesthesia of other agents like your inhalation anesthetic agents and also your, the induction agents, so that, intubation response is suppressed or inhibited when you use midazolam and then fentanyl and lidocaine. So these are all the pre-induction drugs, not for anxiolysis. Second thing is amnesia, anterograde amnesia. That is another very
Yes,
important thing. So that is the reason, as a pre-induction drug, midazolam is extremely popular. And that's what initially only I asked you, almost every day
Okay.
midazolam. Okay, so suppose you want to induce the patient with midazolam. Can we induce the patient with midazolam?
Yes,
Yes,
sir.
sir, we
It's a
can.
cardiostable.
Yeah, very good cardiac stability is there, though it may produce some amount of hypotension, not much because of its effect on the systemic vascular resistance, but not much hypotension. Slight decrease in the blood pressure may occur, but it can be used as an induction agent. But why are we not using it as an induction agent?
Because a dose is more than 0.15 mg per kg can produce apnea in case of midazolam.
All your induction agents will produce apnea.
It'll take time,
And
sir.
then
Slower onset
slower
of
onset.
unconsciousness.
Slightly slower. It may take about 2 to 3 minutes.
Yes,
That
sir.
is one problem. Unlike one arm brain circulation time with your etomidate and gabapentin and propofol, that is one drawback. It may slightly take a longer time. And what is the other problem? Because you only said the induction dose is 0.15 to 0.3 milligram per kg body weight. Quite
Yes,
high
sir.
induction dose, IV.
Yes, sir.
What is the other problem?
The ventilatory response to midazolam would be
No. All those things, all other your induction agents will produce, isn't respiratory depression. Anyway, you are there to manage the ventilation, isn't it? Even if there is
Yes,
a
sir.
you are going to ventilate the patient. You are holding a mask, isn't it? And you are going to intubate and connect the patient to your ventilator. So
Yes,
that's
sir.
not a problem for any induction agents.
They might have withdrawal syndrome. Withdrawal phenomenon post-operatively.
That will not occur with the induction. But what is the other important thing is prolonged duration of action.
Yes, sir.
We want our induction agents to have a short duration of action. Like, for example, if I use penton or propofol, it is usually maximum is 5 to 8 minutes duration of action. So, for example, let us say
Yes, sir.
15 minutes procedure is there, and you want to use the midazolam as an induction agent. So it will be acting for almost 60 to 90 minutes because the duration of action of midazolam is 60 to 90 minutes. And when you give higher dose, it can even act for a longer period and you cannot send the patient. It can even produce post-op respiratory depression.
Yes, sir.
So that is the reason why midazolam is not usually used or a popular induction agent. The other problem with midazolam is, it is not consistent. Some people with 0.15 milligram, they get induced. Other people with even 0.3, 0.5 milligram per kg body weight, they are not getting induced. So that variation, as far as its effect, hypnotic effect, is another drawback of midazolam, why we are not usually using it as an induction agent. Otherwise, where do you use it for induction? When do you use otherwise?
So, actually, if we don't have any opioids availability,
No. Opiates always you have to use when you want to induce. That is what. When do you use a combination of opiates with benzodiazepine? Induction.
seizure patient.
Usually, in those patients where they have, especially patients who are posted for cardiac surgery, and they have a poor cardiac function, especially the left ventricular function is poor, or they have other problems like severe valvular diseases or constrictive pericarditis. Now, those patients, ideal would be etomidate. Etomidate is the ideal. Suppose you don't have etomidate, then the drugs of choice would be combination of fentanyl with midazolam. So very good combination. And why not use only fentanyl for induction?
So,
Why do you want
Fentanyl
midazolam
with,
for induction along with fentanyl?
so it potentiates the activity.
Why not only fentanyl for induction? That's what. Because opiates are, especially fentanyl, absolutely cardiostable drug.
Yes, sir.
Doesn't have any effect on the cardiovascular system. So why not use only fentanyl?
So,
Because
Requirement of opioid reduce.
one thing you should realize, opiates do not produce hypnosis.
hypnosis. No. Yes, sir.
You have to produce hypnosis, isn't it?
Mm.
So it's only midazolam can produce hypnosis.
Hypnosis.
But the dose required for producing hypnosis will be much less when you use opioids also, because they produce fantastic analgesia. Because whenever you have anesthesia, means there are two components of anesthesia mainly. One is hypnosis, another is analgesia. When you are using thiopentone or propofol, you are not producing any analgesia. That is why you also use fentanyl along with that. But here, when you are using midazolam alone, better to use fentanyl also, so that both are cardiostable drugs. But only disadvantage is because you have to use higher doses of these, there will be a prolonged respiratory depression. Both can produce respiratory depression. So anyway, cardiac surgery patients will be on mechanical ventilation even in the post-operative period, and usually prolonged surgeries. So it doesn't matter. That is how, they are quite popular as induction agents, especially benzodiazepines, especially your midazolam, for induction in patients posted for cardiac surgery with problems of low cardiac output, fixed low cardiac output states patients. Okay, so that is about the induction dose. Can we use it for procedural sedation?
Yes, sir.
Yes, sir.
Drug which is quite popular for procedural sedation, isn't it?
Yes,
In
sir.
the, along with the other drugs.
Mhm.
Again, midazolam, fentanyl, propofol combination, isn't it? So because then the requirement of propofol will come down.
Yes,
That's
sir.
how we can use it as a procedural sedation. And many times when you're using regional anesthesia, like peripheral blocks, like brachial plexus block and all, do you use routinely your midazolam as a pre-medicant?
Yes, sir.
Yes,
We
sir.
do use it, sir.
What is the
as a-
advantage of using midazolam as a pre-medicant when you're going in for regional anesthesia?
So,
Advantage.
so patient will be having sedation and anxiolysis. So each time we prick or anything, they won't.
Okay, one is anxiolysis throughout, because
Yes,
regional
sir.
anesthesia, the patient will be afterwards also he'll be awake.
Yes, sir.
So it produces again, the sedation, anxiolysis throughout the procedure. And another thing is, if accidentally, intravascular injection
Yes, sir.
of the local anesthetics are produced. So one thing is, because they're anticonvulsant effect,
Yes, sir.
the patient may not develop any convulsions. So that is an advantage. What is the disadvantage? Whenever there is a local anesthetic systemic toxicity, what is the first thing that occur?
Perioral numbness.
Numbness and metallic taste.
No, that is what, CNS toxicity or the cardiotoxicity?
CNS toxicity.
It's always a CNS
Lignocaine.
toxicity.
Yes, sir.
Now, because the midazolam may suppress this CNS toxicity effect.
You won't recognize the
You
last
won't be able
that
to
we-
recognize
Yeah,
the.
so patient may directly go for cardiac. That is also, people will debate about it.
Oh, yes.
Should we use or should we not use? Because these problems are always there when you use midazolam as a pre-medicant for regional anesthesia. So
Yes.
routinely we are using, isn't it? So the advantages and disadvantages are there. Definitely advantages, because you don't expect the incidence of local anesthetic systemic toxicity is not so common. You are taking a lot of precautions. So mainly it can be used for anterograde amnesia, sedative effect, anxiolytic effect, for as a pre-medicant for regional anesthesia. Okay.
Yes, sir.
So where else you use midazolam?
Epidural, intrathecally.
Yeah, it can be used intrathecally. Yes, as you said, intrathecally as can it produce analgesia?
Yes, sir. Can produce analgesic.
Yeah. Okay.
It acts via the kappa opioid receptors. It produces the analgesic effects
In the spinal cord.
in the spinal cord.
Along with
Postoperatively also.
it was used in probably about 15, 20 years back. It was one of the drugs that was used in many of the, postgraduates used to have their dissertation with intrathecal midazolam. So that's how, the ampules, which do not have a preservative, they were used 5 milligrams per ml ampules. And what is the dose for intrathecal midazolam?
0.3 to 2 mg.
1 to 2 milligrams.
Yes, sir.
1 to 2 milligrams. Usually we used to add either 0.1 ml or majority of the times 0.1 ml because 5 milligram ampules. 0.1 to 0.2 ml we used to add and then give, and it used to produce quite a bit of prolonged analgesia and as an adjuvant for local anesthetics. Again, caudal epidural also, it has been tried. Caudal epidural, same 1 to 2 milligrams. So, or even just even 0.5 milligrams has been added to the local anesthetics and has produced, duration of analgesia has been prolonged. Okay. Where else can be used? Because one of its effects on the CNS.
So awake craniotomy.
No, because of its anticonvulsant. As the patient has, epileptic seizure. So it has been used. Routinely, it is used by non-anesthesiologists like physicians and all. They use midazolam. And I was telling you, nasal spray also for pediatrics.
Yes.
Even adults also, you can use nasal spray for, relief from seizure activity. So one can use midazolam. So these are some of the more common this thing. What is its effect on the postoperative nausea and vomiting?
It increases the postoperative.
Decreases. Unlike etomidate increases PO.
Increases.
Midazolam decreases. They have compared midazolam with ondansetron and they have found equal effect as far as the postoperative nausea and vomiting is concerned. And midazolam has been extensively used in ICU sedation. What is the dose for ICU sedation?
0.4 mics per kg per hour. 0.4 mics per kg per minute.
Can be used 0.25 to 1 microgram per kg per minute.
Yes.
0.25 to 0.1 milligram, 1 microgram. 0.25 to 1 microgram per kg per minute infusion. What is the drawback of using midazolam as an infusion in the ICU?
Prolonged causes the ceiling effect, sir.
Does it have a cumulative effect? We are not bothered about ceiling effect because we are not trying to produce a burst suppression or a flattened. We want to only produce sedation so that the patient can tolerate the tube, tolerate mechanical ventilation in ICU. What about its metabolites? We were discussing.
Yes, sir. It's a
prolonged duration of 1 hydroxy and 4 hydroxy.
Yeah, they accumulate. There is a cumulative effect. That is one problem.
Yes.
So prolonged and sedation can be there because now we encourage sedation holidays, isn't it? What we call sedation holidays, so that we do not want patient to be sedated in the morning from 7 to 11. We want to stop all the sedatives in the ICU so that his neurological status can be examined properly and all. So sedation vacation, sometimes you call it as. And when you use midazolam, this problem is always there that the patient will continue to have sedation because of its cumulative effect. That is one problem with midazolam. So that is one drawback. when you use in ICU. What is the second drawback when you use midazolam for sedation in the ICU?
Causes renal insufficiency.
No effect on the kidneys.
Mm.
The second problem is, the delirium. These patients do develop delirium because of the effect of midazolam. And because of that, they may require more number of days on mechanical ventilation. So weaning can get delayed. So that is another drawback of midazolam. Why I'm telling you all these things is because the other drug, what we are going to discuss immediate next, dexmedetomidine does not have these problems.
Yes, sir.
So that's how, dexmedetomidine is becoming more popular. It
Mm.
actually prevents this kind of a delirium.
Yes,
So
sir.
these are all the important things about midazolam. You want to add anything for midazolam other than what we just now discussed before we go for, the dexmedetomidine, the other important thing.
So this one will have, in case of any overdose, you will have an antidote for
Very good.
Flumazenil
Midazolam.
can be that.
Flumazenil
That's the
can
effect
be
of
used.
Flumazenil is a definitive antagonist of benzodiazepines. And
Yes, sir.
usually, what is the dose of flumazenil? Usually given
Not sure.
0.2 to 0.5 milligram.
Okay.
It's up to 3 milligrams you can go for.
Yes, sir.
It is used for all benzodiazepines, including remimazolam.
Yes, sir.
Antagonizes the effect of remimazolam also. So I still remember when I was there in Bellary long back, almost about 25 years back, we had one medical student. She had consumed, I think about 50 tablets or 60 tablets of diazepam. She intentionally, she wanted to commit suicide. So she had taken and she was brought, and we had to put her on mechanical ventilation. We wanted to antagonize. We did not have in Bellary then flumazenil. So we had to send another intern to Bangalore to get flumazenil. We got few ampoules of flumazenil. Actually, we use flumazenil for her and extremely effective. But only problem, what is the problem with flumazenil when you're using?
Except the respiratory depression, everything else will be reversed.
No, everything will be reversed, including respiratory depression. The problem with flumazenil is it is short acting.
Okay.
So you have to observe. Parthasarthi sir is, duration.
Yes,
That
put
is
it up.
what I told. So it's already good. So thank you, sir. So it is short acting. So you have to observe the patient after giving flumazenil. Suppose it has reversed the effect of benzodiazepines. How long you want to observe the patient?
For 48 hours, we would have to observe the
For
patient.
2 hours.
Okay.
You're guessing, but it is not.
Yes, sir. I'm not sure.
You just have to observe for 2 hours. And for 2 hours, if the patient doesn't get back all the symptoms of the benzodiazepines, depression, respiratory depression, and other things, sedative effects, so then you know that patient need not require much of observation. That first 2 hours is very, very important after giving flumazenil. Otherwise, you may have to repeat the dose of flumazenil. So that is because of its shorter duration of action. So where else flumazenil is used to reverse the, sort of a CNS problems? Where else you use? In hepatic coma. Hepatic coma also, fulminant hepatitis, the patient has gone in for hepatic coma. So one of the drugs that is used is flumazenil because it was found that, the coma may be because of the effect on the benzodiazepine receptors. So flumazenil definitely will reduce the sedative effects or whatever the coma that is there, you are grading it. Already we have discussed grade 1 to 4. Definitely it can bring down the grading of the hepatic coma when you use flumazenil. So good that you brought out flumazenil. Otherwise, I would not have discussed about flumazenil. Okay. Anything else regarding benzodiazepines, especially midazolam, because it is a drug that usually will be kept there for exam purpose. So can we discuss about dexmedetomidine?
Yes, sir.
And don't say Dexam in the exam because Dexam is a trade name. So
Yes, sir.
always identify the drug with its generic name or with its pharmacological name. Okay. Let's say it is an ampule containing dexmedetomidine.
Yes, sir.
Okay. So now coming to dexmedetomidine, what group of drugs dexmedetomidine belongs to?
Alpha agonist, sir.
Selective
Alpha 2.
You have to be very specific.
Selective alpha 2 agonist.
alpha 2.
You can't say just alpha agonist because you have alpha 1 and alpha 2 receptors are there, isn't it? So alpha 1 receptor agonists are different. Can you name some alpha 1 receptor agonists?
Clonidine.
Clonidine, both non-selective
Clonidine
alpha
also
1
alpha
and
2.
It will be for both.
Alpha 1. Can you, I'll give you a clue, vasopressors. What common vasopressors you'll be using?
I didn't.
A. Most common vasopressor, phenylephrine,
Yes, sir.
phenylephrine, ephedrine,
Yes, sir.
methamphetamine,
Yes,
isn't it?
sir.
Metaraminol. Of course, noradrenaline, adrenaline also can be used, but they're all alpha 1 agonists, especially phenylephrine is a very strong alpha agonist, the alpha 1 agonist. That is why when you are answering, you should be careful because, discussion can lead to something else,
Yes,
which
sir.
you are not prepared to answer, or your brain would suddenly will not change, isn't it, to that aspect. That is why when I asked you alpha 1 agonist, so you were not knowing what to answer. So you have to be careful in the exam. So you be precise with your answer.
Yes,
So
sir.
highly selective alpha 2 agonist. Why I'm telling highly selective alpha 2 agonist, which is the other alpha agonist, which is not so selective when compared to dexmedetomidine. You mentioned one more.
Clonidine, sir.
Huh?
Clonidine, sir.
Clonidine. What is the alpha 1 to alpha 2 of clonidine and dexmedetomidine ratio?
220 is to 1
1
for clonidine. 1640 is to 1 for dexmedetomidine.
Nearly about 8 times.
Yes,
More,
sir.
Dexmedetomidine is 8 times more selective
more selective.
for alpha 2 when compared to clonidine. Which drug was introduced first, clonidine or dexmedetomidine?
Then clonidine was introduced.
You're sure? Yeah, clonidine was introduced in 1960s only. First, clonidine was introduced for what purpose?
Eclampsia.
Hypertension.
Introduced
For
for nasal decongestant, as a nasal decongestant. So for nasal decongestion, it was introduced. But when the patients used it, they also had fall of blood pressure. Then they realized it can be used as an antihypertensive agent. That's how, clonidine was started being used as antihypertensive agent. All alpha 2 agonists, centrally acting alpha 2 agonists are antihypertensives. Can you name some other alpha 2 agonists which are used for control of blood pressure? Especially in pregnant women, other than clonidine. What is one of the most commonly used antihypertensives, maybe about 10-15 years back in obstetrics? Have you heard about alpha methyl dopa?
Yes, sir. Yes,
Yes,
sir.
sir.
Right. So alpha methyl dopa is basically it is an alpha 2 agonist,
Okay.
centrally and peripherally acting alpha 2 agonist. That is how alpha methyl dopa, aldomet, which was a popular trade name. So usually used as an antihypertensive agent. Is there any other antihypertensive agent which also has an alpha 2 agonistic activity, mainly acts on alpha 2 agonistic activity in the CNS, now not used much, hardly used, but introduced by an Indian from Rolfia alkaloids, Rolfia serpentina. That is from a plant. Now, these kind of questions we'll be asking, to give you more marks in the exam. We know that you will not answer, but if you answer, you will get more marks. When you are asked, you remember when such questions are asked, that means you're answering very well. That is why we want you to know that you don't know much also. There are many things which you require to know. That's how we do ask such questions, and if you answer, definitely you'll be getting more marks. That is reserpine. Have you heard about reserpine?
Yes, sir.
You know about reserpine, which was one of the very popular drugs maybe about 40, 50 years back as an antihypertensive agent. Rustum Jal Vakil, one of the most famous physician in Bombay, he is been credited for introducing that drug in India, reserpine.
Yes, sir.
It is from Rolfia serpentina, that is a plant extract. So why it was discontinued, reserpine? Because it could produce suicidal tendencies in many of the patients. So that's how it's again on alpha 2 agonists. All these alpha 2 agonists, centrally they produce sympatholysis, and peripherally also they produce sympatholysis. That's how they have been used as antihypertensive agents. Clonidine, nowadays clonidine can it be used as a first line drug for hypertension?
No, sir. We are not using this.
Yeah, it is used as in resistant
The
hypertension,
refractory hypertension.
especially chronic kidney disease patients. They require 3-4 drugs for control of their patient. So one of the drugs that is used is again clonidine. What is the dose of clonidine for oral antihypertensive? It is usually 100 to 200 micrograms, 2 to 3 times a day.
Yes, sir.
100 micrograms. Tablets are available.
Yes, sir.
So that you should always know. But nowadays, clonidine we are not using as an antihypertensive agent routinely, but for resistant hypertension we use it. And clonidine nowadays mainly used as analgesic. More along with local anesthetic, it is more often used as analgesic. Okay, coming to the alpha 2 receptors, where they are concentrated in the brain.
Locus ceruleus and substantia gelatinosa.
Substantia gelatinosa, where it is? It is in the
Gelatin. That is in spinal.
spinal
cord.
Yes, sir.
The brain is
Only locus ceruleus.
in the brainstem, the locus ceruleus and area postrema. So these are areas where there is highly concentration, lot of alpha 2 receptors are there. So our alpha 2 agonists, whether it is reserpine, whether it is clonidine, or whether it is alpha methyl dopa or dexmedetomidine, all these will be acting on these alpha 2 receptors. What they produce by acting on alpha 2 receptors?
Vasodilatation, sir.
No, what they produce? They have any effect on the release of any?
It inhibits the release of the norepinephrine, sir.
Norepinephrine.
Norepinephrine release.
Right. So they produce circulating catecholamines. They're the decrease in the
They
circulating.
reduce it.
That means they produce what is called as a central sympatholysis.
Yes, sir.
Sympatholysis, unlike your ketamine, which increases the sympathetic outflow,
Yes,
it
sir.
is quite opposite.
Yes,
Opposite
sir.
of ketamine. So they produce sympatholysis. So that's how, their effect on the cardiovascular system. So the alpha-2. And do we have alpha-2 receptors peripherally also?
Yes, sir.
sir.
We have
Peripheral tissue.
alpha
Where
2A,
they are alpha-2?
presynaptic and postsynaptic 2A receptors are there. Presynaptic action will cause vasoconstriction, whereas
No. Be careful when you answer. Presynaptic, over the nerve ending, you have alpha-2 receptors, isn't it?
Yes, sir.
When they get activated or stimulated, what they do?
Presynaptic will inhibit the norepinephrine release. Sir.
Yeah, they have a counter regulation, isn't it? So they immediately decrease the release of norepinephrine from the nerve ending. That is what the alpha-2 receptor stimulation that occurs. That is what, when, normally whenever whenever a stimulus comes through the autonomic nerve ending, so norepinephrine is released and it produces effect on the alpha-1 receptors on the smooth muscles, producing vasoconstriction, isn't it? The meantime, its effect is suddenly decreased by, one is by reuptake of norepinephrine into the nerve ending. Second thing is the catechol O-methyl transferase that is present in the synapse. It will metabolize this norepinephrine. The third thing is it acts on the alpha-2 receptors on the presynaptic nerve ending and it decreases its own release. Further release of norepinephrine from the autonomic nerve ending is decreased. That's how the effect of alpha-2 stimulation. And you said something about alpha-2A, 2B, 2C. These are, subunits.
Yes, sir.
Alpha-2 receptors. So you have alpha-2A, 2B, and 2C. Where are these present? 2A, where 2A is present, 2B is present, 2C is present. Because I would not have asked you because you mentioned. Now that is what, in the exam. When you mention, you should know what can, chain of questions that can start off.
2A is present in the peripheral tissues, sir. Postsynaptic and presynaptic.
2A and 2C mainly in the central, both in the brain as well as in the spinal.
Yes, sir.
2B is in the over the smooth muscles. It is present over the smooth muscles, because you should know about this also, because these alpha-2 receptors are also present over the smooth muscles. Activation of these alpha-2 over the smooth muscles can produce vasoconstriction. So that also you should know about. So you have alpha-2A, 2B, and 2C. 2A and 2C are mainly present in the CNS, and 2B is peripheral.
Yes, sir.
Okay, now we have dexmedetomidine. So whether it is, how it is available? Is it available in the vial form or an ampule form?
It's an ampule
Ampule form.
Okay, what is the strength?
100 mics per ml, sir.
Yeah, 100 mics per ml. How many ml each ampule?
1 ml ampule.
1 ml ampule.
1 ml. Yes.
Yeah, available as 1 ml ampule.
Yes.
So each ml is 100 micrograms. What about clonidine?
Yes, sir.
Available as
Clonidine will also come as
ampule.
ampule, sir.
Each ml is
150 mics will be there per ml.
each ml.
Each ml will contain 150 mics, sir. Clonidine.
300.
So here
150 is it?
150 we get over here.
Yes. Yeah. 2 ml ampules you have.
Yes, sir.
1 ml ampule
we have
sir.
1 ml ampule.
That comes as 150 mics per ml.
Yeah, we have 2 ml ampules also available. So
Okay.
that is 300 micrograms in.
Okay.
So good that you know about that. Dexmedetomidine is available as 100 micrograms per ml, because many times you'll have to dilute it quite a bit. Isn't
Yes,
it?
sir.
When you want to give us an infusion also, you'll have to dilute it and then you give it. Okay.
Yes.
So now coming to the mechanism of action of the dexmedetomidine, already we have discussed. Mainly it acts on the locus coeruleus, alpha-2
Yes.
receptor, then area postrema. And what is its effect on the CNS?
So this one it will decrease the ICP and it will decrease the cerebral metabolic oxygen requirement.
Same
Not
R2.
much, isn't it? Not much effect over
Not much.
cerebral blood flow, then ICP and
Yes,
CMR2
sir.
marginally decreased, but not much effect. But
Yes, sir.
basically, what it produces?
Anxiolysis and dose-dependent
Amnesia.
amnesia.
Dose-dependent
It
amnesia.
produces very good sedation.
Yes, sir.
And it also produces sleep, isn't it?
Yes, sir.
So sedation and sleep. So what is the difference between, because we were discussing about midazolam, and now difference between midazolam induced sedation and dexmedetomidine induced sedation. What is the difference? Both are going to
This is
increase.
an arousable
Arousable sedation.
sedation.
Pardon? Yes, very good.
Arousable sedation.
Arousable sedation with dexmedetomidine. What do you
Dexmedetomidine.
mean by arousable sedation?
Oh.
So even
You
if
mean
you
to
put
say
a
that when you give midazolam, patient will not get up, is it, or wake up?
so actually the so since the metabolites of the midazolam is present in the body, it will prolong.
No, you should always think where midazolam acts and where dexmedetomidine acts.
Yes.
All these GABA mimetic drugs, or which act on the GABA receptors, they don't produce natural sleep.
Yes, sir.
Listen.
Okay.
So that's how the patient, even though slightly more dose, the patient will not be able. You may not be able to wake up the patient. They will sit in sedation. Whereas dexmedetomidine, being it is acting on the alpha-2 receptors, and there is also communication with these alpha-2, the area postrema, with reticular formation. So they also depress the reticular formation. So whenever a reticular formation is depressed, it produces a natural sleep. When you wake up the patient wakes up as if he has just woken up from sleep. For example, you are in deep sleep in the night, you get a call, your phone will ring. You got a call from the hospital. Now, will you wake up immediately and then get dressed and then rush to the hospital, isn't it? It is like that. Because it produces natural sleep. So that so what is the advantage with this arousable sedation? It is called as arousable sedation. Why? What is the advantage of dexmedetomidine? Why it's so popular in ICUs?
So when we stop infusion within 10 to 15 minutes, patient will be awake.
Even if the patient is on dexmedetomidine also, the patient can be woken up. If you don't stimulate him, if you don't wake him up, he'll sleep off. If you wake him, he'll wake up. And he'll answer all your questions and whatever that is there. So that is an advantage. Because I was talking to you about sedation vacations, isn't it? So you can continue with dexmedetomidine, and still, the patient can wake up and, you can examine his CNS and the other things in the ICU. So that is a very good advantage of dexmedetomidine, because it does not produce GABA receptor inhibitions. So it's mainly its effect on the alpha-2 receptors. So arousable sedation, that is one very important thing. Okay, so that is about its effect on the CNS. Now coming to the effect of dexmedetomidine on CVS.
So it
reduces. It reduces the heart rate. It reduces the heart rate. Systemic vascular.
Basically, it is a sympatholytic drug.
Yes, sir.
Is it an adrenergic drug or adrenolytic drug? You classify it as adrenergic drug or?
Adrenolytic drug.
It is an adrenergic drug, isn't it? Alpha-2 receptor is an adrenergic receptor. It's an agonist.
Yes, sir.
So it is an adrenergic drug, but it acts mainly on alpha-2 receptors. So it produces central sympatholysis, and peripherally also it decreases the release of norepinephrine, both central and peripheral effects. Because of that, its effect on the heart, as you said, it decreases the
heart rate.
Okay, then
Heart rate and the contractility.
Decrease the negative inotropic effect is also there.
Yes, sir.
And
Then systemic
reduction
vascular.
in cardiac output also. Systemic vascular resistance also reduced.
Systemic vascular resistance is decreased. So because of these, it is an advantage or is a disadvantage when you use it as a pre-medicant drug or pre-induction drug?
So it is pre-induction, it is.
Are you routinely using dexmedetomidine for many patients?
No, sir.
You're using routinely?
Routinely, we are not using
Yeah,
it.
in many places now dexmedetomidine has become a routine pre-medicant. So usually it is used so that, it is used as an advantage because one thing is that, it produces a decrease in the heart rate and decrease in the blood pressure so that whenever you do a laryngoscopy and intubation, there is a suppression of sympathetic response because it's a sympatholytic drug. So both clonidine and dexmedetomidine have been used for this particular effect of suppression of the intubation response, laryngoscopy and intubation response. And that is one thing. Second thing is it produces more, depth of anesthesia, or it produces more increased depth of anesthesia along with inhalation anesthetic agents and IV anesthetic agents. So you don't require much of anesthetic drugs intraoperatively. So when you use dexmedetomidine, that is another advantage. Third thing is they themselves have produced analgesia by their effect on, as you said, that spinal cord and also on the brain, because they inhibit the noradrenaline release in the brain so that the descending pathway, they activate the descending inhibitory pathway and also their action on the spinal cord, alpha-2 receptors in the spinal cord. They produce analgesia and they potentiate the analgesia of the opioids. So that is another advantage of using dexmedetomidine as a pre-induction drug. The third thing is, I was telling you that it also decreases the emergence delirium. Some of the patients, especially the pediatric patients and some geriatric patients, are prone for emergent delirium. And this emergent delirium is decreased by dexmedetomidine. So another advantage of using dexmedetomidine as a pre-induction drug. And the other thing is it can be continued even in the postoperative period. Why it can be continued even in the post-op? What is the advantage? For example, now I want to continue midazolam or propofol or fentanyl in the postoperative period. What is the disadvantage there and what is the advantage with dexmedetomidine? Its effect on the respiratory system. We'll come back to CVS, but its effect on the respiratory system.
It maintains the respiratory functions. The other
Does
two.
not produce any respiratory center depression. It is a unique property of dexmedetomidine. Unlike your fentanyl, your benzodiazepines like midazolam, your propofol, all these drugs will produce a central respiratory depression, isn't it? So that's what just now we were discussing about midazolam. Along with opiates, they produce extensive prolonged respiratory depression. But advantage of dexmedetomidine is it does not produce respiratory depression. So even if you are continuing into the after extubation also, patient will be absolutely fine. There won't be any respiratory depression. But what is the one problem with the respiratory depression, or problem with dexmedetomidine as far as the respiratory system is concerned?
Reduces the minute ventilation.
What it can produce? No, it won't produce no effect on the ventilation or respiratory rate. No problem. That is how now it is quite a popular drug. What is the one because of its extreme degree of sedation it can produce? Peripherally, what it can produce as far as the airway is concerned? Airway can produce falling of the tongue may fall back, airway obstruction. So you require some nasopharyngeal or a oropharyngeal airway. That's all.
Oropharyngeal airway.
For oropharyngeal or nasopharyngeal airway, because sedation can produce falling back of tongue, epiglottis, uvula, all those things, and that can produce upper airway obstruction. So that you have to look after by using a nasopharyngeal airway if you just put it. patient will be very comfortable with dexmedetomidine. That is an advantage of dexmedetomidine in the respiratory center. Coming back to CVS effects, so it produces, decrease in the heart rate, decrease in the blood pressure. So it's advantage. And especially in those patients with ischemic heart disease, where, by depressing the myocardium, by decreasing the heart rate, it decreases the demand, oxygen demand, so that the balancing of oxygen supply demand can be there. So that is why in patients with ischemic heart disease, definitely it is an ideal drug to be used. And also in, for example, now, let us say that valvular heart diseases, aortic stenosis, or mitral stenotic patients, where you do not want to increase the heart rate. Any increase in the heart rate, definitely, the diastolic period is very important, during which the left ventricle will fill, isn't it? In case of mitral stenotic patients. So any increase in heart rate suddenly can produce a decrease in the left ventricular filling, increase in the left atrial pressure, the back pressure effects, pulmonary edema can occur. Especially when you are doing an intubation, laryngoscopic intubation, patient is going in for pulmonary edema. So when you use dexmedetomidine, definitely by its effect on the heart rate, by decreasing the heart rate, it is quite helpful. So that's how, its effects on the CVS can be utilized for benefiting the patient, isn't it? Other than this, you have to be extremely cautious also, because can produce severe hypotension.
And radical.
It can produce, especially in patients with already having a bradycardia, more severe bradycardia, even heart blocks can occur. Or patients with heart blocks, intense bradycardia can occur. So that you have to be careful about. And for that, sometimes you may have to use glycopyrrolate or atropine. You have to keep it ready. As long as you keep it ready, there is no problem.
Yes, sir.
Okay. Now, what is the pre-medicant dose you will be using? No, we'll come to that dose later. Okay. Its effect on the respiratory center. Already we just now discussed about its effect. What about its effect on the airway reflexes?
Keeps it in character, sir. The reflexes are maintained.
Yeah, it maintains the airway reflexes. What about the effect on bronchioles?
Not cause bronchodilatation.
No, it does produce bronchodilation, though it's a sympatholytic drug. It does direct effect is bronchodilation, but does not produce any bronchoconstriction because of this disease. So it is, can be used in patients with hyperreactive airways disease. So not it's an advantage only in hyperreactive airway disease. Okay. Now the other effects of dexmedetomidine on the hepatic blood flow.
Reduces the hepatic blood flow, sir. And
And because of its effect on the cardiovascular system, by decreasing the cardiac output, decrease slightly the hepatic blood flow is decreased. Okay, now how do you administer dexmedetomidine?
sir, 1 mic per kg per bolus IV dose is given, followed by an infusion of 0.2 to 0.7 mics per kg per minute.
Okay. Now, why do you want to use, though you call it as a bolus, but you are mixing it with 100 ml of saline?
Saline.
Isn't it? 1 mic per kg body weight, you calculate maybe 50 or 60 milligrams. You dilute it in 100 ml of saline and you give over 10 to 15
10 minutes.
Why should you do that? Why should you give over 10 to 15 minutes? Why not rapidly direct IV? Why don't you push it?
That will cause sudden
And
bradycardia.
hypertension and bradycardia. Sudden.
Only bradycardia?
And hypertension.
Sinus.
Yes, correct. And hypertension. Very good.
Yes,
So
sir.
why it produces hypertension? It's called as a U-shaped curve. When you give rapidly, blood pressure will increase. When you give it slowly, the blood pressure will decrease. That is why it has been described as a U-shaped curve on the blood pressure. Why it produces hypertension when it is given rapidly IV direct without dilution. That is why you should understand this particular effect of dexmedetomidine. Because when you give directly IV, do you know, Geeta, you are trying to answer? Direct effect.
Not sure. Acts on the alpha-2A receptor, the vasoconstriction causes
Very good.
hypertension.
Alpha-2B receptors.
2B
Peripherally,
receptor.
alpha-2B direct
Yes.
effect. It also, because, it is 1:1600. That one is also there. It can also act on the alpha-1 receptors when it is given rapidly. And it can also act on the alpha-2B receptors on the smooth muscles of the arterioles and can produce sudden vasoconstriction and can produce sudden increase in the blood pressure. And, baroreceptor activity will be there. And so that is bradycardia also. Hypertension and bradycardia can occur. So that is the reason why you always dilute it in 100 ml and give it very slowly over 10 to 15. Okay, so that's how you always administer. Then, you said that 0.2 to 0.5 micrograms per kg per hour or per minute?
Per minute.
Per kg per minute, sir.
Maintenance dose.
Minute.
Sir, per hour. So,
It is per hour.
yes, sir, per hour.
0.2 to
Per hour.
0.2 to 0.6 microgram per kg
Per hour.
or maintenance dose. So because of its does not have any effect on the respiratory center, definitely you can use it. So what about the uses of dexmedetomidine? Where all you can use it? One use already we said as a pre-induction drug and maintenance drug. Definitely you can use. A lot of people, especially a lot of students have studied on dexmedetomidine in laparoscopic surgeries. By laparoscopic surgeries, it is quite popular as a maintenance drug also.
Nice.
Reduce hypertension.
Now, during laparoscopy, will there be any increased sympathetic activity?
Yes, inflation can cause increase in the heart rate. Dexmed.
What causes actually increased sympathetic activity?
Causing pneumoperitoneum, there can be an increase in heart rate.
No, the increase in the pneumoperitoneum can produce a decrease in heart rate, isn't it? Sometimes even cardiac arrest because sudden vagal mediated bradycardia and arrest can occur. But what is the gas that is used for pneumoperitoneum?
CO2,
Carbon dioxide.
Yes.
So it's going to be absorbed, isn't it? What is the effect of carbon dioxide? Increase in carbon dioxide on the sympathetic system.
Increases the sympathetic
hypercarbia.
Increase in sympathetic activity. Both hypoxia and hypercarbia, they both increase. So there is a continued increase in the heart rate and blood pressure in these patients. Got back the power, isn't it?
Yes, sir.
Suddenly your faces became bright.
Yes, sir.
You can answer better now, I think. So that is what, that sympathetic activity is there. So that's how, in laparoscopic surgeries, one of the very good drug for maintenance. Okay. So barring these, what are the other? Can we use dexmedetomidine as a pre-medicant in pediatrics?
We can, sir.
How it is used?
As a nasal spray with ketamine.
Yeah, correct. One is as a nasal spray. Second thing is as a, nebulization. You can use it as a nebulization route. That is what inhalational route. So both the ketamine and dexmedetomidine combination have used that because each one will have nullify the side effects of the other. Like ketamine increases heart rate, dexmedetomidine decreases heart rate.
It's the heart rate, yeah.
Ketamine produces increase in myocardial contractility, dexmedetomidine decreases the myocardial contractility. And ketamine increases the blood pressure, dexmedetomidine decreases the blood
Decrease the
pressure.
blood pressure.
Combination, like yesterday we were discussing ketofol, like that, a combination of ketamine and dexmedetomidine, especially in pediatric age group, has been used as a nebulization. Ketamine in the dose of 3 to 5 per kg body weight for nebulization, and dexmedetomidine is 1 to 2 mics per kg body weight. So both are combined in the same this thing and nebulized. Within just about 15 minutes, children will be very comfortably sedated. They can be separated from their parents and then taken to the operation room. The other thing is nasal spray. You can spray dexmedetomidine 1 microgram per kg body weight. Nasal spray also you can administer for pediatrics. Okay, so where else you can use dexmedetomidine? Pardon?
Difficult intubations, the fiber optic intubations.
So it can be one of the drugs to produce very good sedation. Should you do airway blocks, or without airway blocks, you use only dexmedetomidine for?
Along with the airway blocks.
Along with the blocks.
Along with airway blocks, the patients will be very comfortable. When you use nasotracheal fiber optic intubation, it is one of the drugs that is extensively used for producing very good cooperation. Because, for this awake into fiber optic intubation, you require very good cooperation from the patient. So when you use 1 mic per kg body weight and then continue to use Dexam. So what is the half-life of or contact sensitive half-time of when you use 1 mic per kg body weight? How long the effect will last?
15 to 20 minutes.
Contact sensitive half-time is how much? Because you are using it as an infusion. Once you stop the infusion, how much time it takes for the drug concentration to fall by 50%?
Infusion over 18 hours, 3 hours.
No. Single, when you use a 1 mic per kg body weight, it is 4 minutes. Contact sensitive half time is 4 minutes. But when you use it for 8 hours, like propofol we were discussing day before yesterday. So when you use it for 8 hours, propofol has got 40 minutes.
Infusion.
Half time. Whereas dexmedetomidine, what is the contact sensitive half time when you use it for 8 minutes? Usually it has got a contact sensitive half time of 250 minutes. 250 minutes contact sensitive half time when you use for infusion. For single infusion of 1 mic per kg body weight, contact sensitive half time 4 minutes. 4 minutes. And when you use it as a for 8 hours, it is almost 250 minutes is the contact sensitive half time. So, okay. So you can use it for awake fiber optic intubation. Where else it is used? We are also talking about one of the most popular uses in CNA, in neurosurgeries.
Awake craniotomy.
Awake craniotomy. Especially it is extensively used along with the blocks, the scalp block for awake craniotomy. Dexmedetomidine is one of the most commonly used drugs. So when you use dexmedetomidine, what about, can you monitor the patient using your BIS monitoring? Depth of anesthesia. Like we were talking about ketamine, BIS is of no use. Though patient is deeply anesthetized, but BIS will be more than 90 with ketamine. What about with dexmedetomidine? It's the same problem with dexmedetomidine. You cannot rely on BIS when you're using dexmedetomidine. So you cannot gauge the amount of sedation or the depth of sedation or anesthesia using bispectral index. So that is there. So awake craniotomies, dexmedetomidine, why it's a very popular agent for awake craniotomies?
So a patient will be arousable, sir.
One is arousable sedation. So they map the user focus. They can always wake up the patient and talk to him and stimulate him so that they can know where exactly is the scissor focus. One, what is the other advantage? We are already discussed. It's the effect on the respiratory system.
ICP will be decreased, sir.
It reduces the
Effect on the respiratory system.
CMR
Effect on the respiratory system.
and the ICP.
No, still, are you not able to hear me or what? Effect on the
So now
respiratory.
only we're
Yes,
able to
sir.
hear you,
Now
sir. Between went off, sir.
No, effect on respiratory system. I'm giving you a clue.
No changes in the
Yeah, it does not produce respiratory depression.
Yes, sir.
When you want the patient to be awake,
The patient
maintains
you don't want any respiratory depression. Suppose you give propofol, you require to assist his ventilation.
Yes.
Yes, sir.
So you can use propofol, that is for sleep awake craniotomies. There is another form of awake craniotomies where you go for sleep awake sleep. In between, you wake up and again you knock off. So, but when you use dexmedetomidine, these problems are not there. So, patient will be deeply sedated, arousable sedation is there, plus there is no respiratory depression. So, that is the reason
Yes, sir.
why dexmedetomidine is a popular drug as far as awake craniotomies are concerned. Okay, where else you use dexmedetomidine?
So for any daycare procedures, they can use, or any local case they want to take.
Can it be used as an adjunct to local anesthetics?
Yes, sir.
Is it being used for epidural intrathecal?
Yes,
Yes,
sir.
sir.
It can be used, sir.
No, because its effect on, as you said, substantia gelatinosa and alpha-2 receptors in the spinal cord. It also can prolong the duration of analgesia of the local anesthetics. And it by itself can produce quite a bit of analgesia in the spine through the spinal cord, its effect on the spinal cord.
Yes, sir.
So what is the dose, intrathecal dose that is used?
The intrathecal dose is point.
So you 5 to up to 15 micrograms.
Okay.
Not per kg body
Yes,
weight.
sir.
5, 10, 15. They have found 10 micrograms to be ideal. One of our students actually did a study comparing 5, 10 and 15 micrograms intrathecally along with bupivacaine. Found 10 micrograms to be to produce quite a bit of prolonged duration of analgesia. Including clonidine also has been used intrathecally. Clonidine, routinely
Yes, sir.
clonidine. You must be using clonidine? Are you using clonidine intrathecally?
Yes, sir. We have, sir.
How much you are using clonidine intrathecally?
30 months we are using.
30 mics. So it can be used.
Yes.
15, 30, up to 75 mics has been used along with local anesthetics. Produces quite a bit of prolonged analgesia. Can dexmedetomidine and clonidine be used in the caudal route, caudal epidural route?
Yes.
For caudal analgesia along with local anesthetics.
Not sure, sir.
Again, extensively used both clonidine and dexmedetomidine. Clonidine 3 microgram per kg body weight and dexmedetomidine 1 microgram per kg body weight.
Yes,
Both
sir.
produce extensive analgesia up to 17 hours.
Okay, sir. Okay.
That is there. But which one is more popular? Is clonidine is more popular or dexmedetomidine is more popular as for caudal analgesia? Even intrathecal also you use more of clonidine than dexmedetomidine. Why? Both are equally effective, but why clonidine is more popular?
Cost, because Dexmed is more expensive.
Yeah, definitely. Cost-wise, clonidine is much cheaper when compared to dexmedetomidine, and the duration of analgesia is similar with when you use dexmedetomidine or clonidine in the caudal epidural for our intrathecal use. So that's how clonidine has become more popular. So that is one of the uses of clonidine or alpha-2 agonists, clonidine or dexmedetomidine. Okay, where else Dexam is very popular?
So in ICU sedation and
Yeah, very good. ICU sedation. Very effective ICU sedation because unlike midazolam, it won't produce delirium.
yes, sir.
It is an advantage. Second thing is arousable sedation. Third thing is it does not produce any respiratory depression. What is the problem in ICU when a patient who is on a mechanical ventilator, it produces respiratory depression. The drug that is used for sedation produces also respiratory depression.
It will be hard to
weaning off
weaning off
mechanical.
Yeah, because he'll require more support from the mechanical ventilator. If he requires more support, means more longer will be the time for taking him off from the ventilator or weaning him off from the ventilator. That's how dexmedetomidine definitely is going to help in such situation. What is the FDA approval for dexmedetomidine in ICU for the duration of use?
less than
24 hours.
They not less than 24 hours, up to 24 hours.
Okay, yes, sir.
But in other European countries, especially in Japan and all, other than Asian countries, Japan, even in India, we are using for more than 24 hours. And we are extremely happy with dexmedetomidine, one of the very commonly used drugs in the ICU. So what is the dose that you use in the ICU?
So 0. So it's
Same 0.2 to 0.5
0.2
kg per hour. That is
yes,
the
sir.
dose what you use.
Yes, sir.
Okay, so that is for ICU sedation also. You can definitely use. So what are the other advantages of dexmedetomidine? Where else it can be used actually? Can it be labor analgesia? Has it been used? Along with the epidurals,
Yes, sir.
IV sedation.
Yes, sir.
Not only one is sedation, and also enhances the analgesic effects of the local anesthetics and the opioids. So it has been used for labor analgesia also. And what about the peripheral blocks? Brachial block.
Yes, sir.
Yes, sir.
It
Can be used along.
Are you using in your department?
Once or twice we've
Not-
given before, so
Not on a regular
consistently.
basis.
That means you can use, isn't it?
Yes,
So
sir.
definitely they prolong the duration of analgesia of local anesthetics. So
Yes.
what is the other important use? Especially, for example, now sometimes pethidine is used for this purpose in the postoperative period.
Shivering.
Shivering.
It increases the shivering threshold.
Yeah, so dexmedetomidine has been used. For example, if the patient has shivering, so you can definitely try dexmedetomidine. It can produce, effective relief of shivering. That is also one of the effects of dexmedetomidine. And the other important thing about dexmedetomidine is it has got organoprotective effect. Especially, it has been found, especially when it is used in critically ill patients, it reduces the incidence of acute kidney injuries. That is a very good, organoprotective effect of dexmedetomidine. So that is how, it is an additional advantage when it is used in critically ill patients in ICUs. Acute kidney injury incidence is quite a bit of decrease. The incidence decreases quite a bit when you use dexmedetomidine. So these are some of the uses of dexmedetomidine. Any other use you know of?
For TIVA, you can use
Along with TIVA, definitely.
yes, sir.
And also in opioid-free anesthesia. That is what we're discussing about.
Yes,
So,
sir.
I think these are the things about dexmedetomidine. Actually, I thought of discussing about inhalation anesthetic agents also today, but we had an extensive discussion on these two drugs. So let us see anything in the chat box.
Sir, regarding the drug interactions that we have not discussed
What
for
drug interaction?
midazolam with cytochrome P450 inhibiting drugs. So,
Yeah, midazolam with propofol. That is what is one of the things that when you use midazolam, the propofol duration of action may be prolonged. The vice versa. It is always vice versa also, because both will decrease the hepatic blood flow, both will reduce cytochrome P450 enzymes. That is what in the initial, when we were discussing about propofol, probably you people might have forgotten. So I had told about this.
So I actually have one doubt, sir, regarding
Yeah.
midazolam. So
Yeah.
normally we used to be advised not to give midazolam along with. I mean, no, sir. Actually, we were advised not to give midazolam along with chronic alcoholics, sir, because many times whenever we administered midazolam, uh, patient used to just it would come as like a ketamine effect for them, sir. They would randomly blabber anything, or they would shout in the OT. So, is, is
No,
there any correlation for
the
it, sir?
main
Because
problem with in these patients with who are alcoholics, prolonged, they have a tolerance for all these drugs. For all benzodiazepines or whatever hypnotic agents, they have a tolerance. So one of the drugs that are usually given for alcohol withdrawal are benzodiazepines. You actually use them.
okay,
But
sir.
dexmedetomidine may be a better drug than midazolam, or you have to combine it with other drugs for these patients, chronic alcoholics. But the dose that they require is much higher because the tolerance they have. One. The other thing is alcohol is a enzyme induction agent.
Okay, sir.
When you're using all these drugs as an infusion, so their duration of action may be decreased. The chronic tolerance they have is one of the problems. So some more questions, can you read?
Does MAC reduce for inhaled anesthetic with Dexmed?
MAC definitely, because I already told you that because dexmedetomidine produces sedation, all these drugs which produces sedation can also have an effect on the MAC. So the requirement of inhalation anesthetic agents definitely will come down, whether it is benzodiazepines or opioids or whether dexmedetomidine. Some amount of decrease will be there.
Okay. So another doubt, sir. Always like for we don't administer midas when it comes to emergency LSCS or those cases because it might cause floppy baby syndrome. But in case of an actual emergency, so where there is a lot of deceleration for the babies, who they want to immediately operate and they will deliver the baby within 2 to 3 minutes of incision.
Where you have to give GA.
Yes, sir. When we have to convert it to GA, can we give midas, sir? Because it will be a traumatic experience for the patient because they might be.
No, benzodiazepines are not contraindicated in patients post for anesthesia for cesarean section.
Okay, sir.
Mainly, for labor analgesia.
Okay, sir.
You have to use continuously.
Okay.
And people have used diazepam, which has got a prolonged duration of action in the baby, because especially the desmethyl-diazepam, one of the the metabolites of diazepam has got nearly more than 100 hours of half-life in unit. That is going to produce quite a bit of floppy infant syndrome and all, because they were trying all these drugs because they did not know this epidural analgesia much. They were using all kinds of drugs. So, but for cesarean section, you definitely have to use drugs but you don't use opioids before extracting.
Delivery of the baby.
So
Yes,
because
sir.
you are not using opiates, you have to produce better anesthesia, hypnosis. So that's how, midazolam is one of the drugs always you have to use. Use
Yes,
midazolam,
sir.
use lidocaine, use propofol, you intubate the patient, you use nearly 1 mg of inhalation anesthetic agent initially, use 50% of nitrous oxide, you ventilate, and once the baby is extracted, you give opiates now.
Okay,
Okay,
sir.
sir.
Yeah,
Now
we need to give some answers.
you reduce the inhalation anesthetic agents, now you can increase the nitrous oxide. Because
Okay.
why you don't use more than 50% nitrous oxide for before delivery is the baby requires more oxygen.
Oxygen.
You have to keep an FiO2 of 50.5. That is why nitrous you give 0.5. That is the reason why you have to increase the inhalation anesthetic agent.
Okay, sir.
Yes, sir.
Nearly 1 mg or slightly higher than 1 mg. But afterwards, you cut down the inhalation anesthetic agent because inhalation anesthetic agents, they produce relaxation of the uterus.
Uterus.
You cannot continue afterwards. You have to reduce. You cannot continue with the same higher concentration. You have to reduce. So midazolam is not contraindicated for cesarean section.
Okay.
Definitely you have to
Yes.
use.
Okay, sir. So we have one more question, sir.
Yeah, yeah.
Post-delirium effect of ketamine.
Post-delirium.
Effect of ketamine.
Can Dexmed be used for
For-
post-delirium?
Dexmedetomidine, but usually for emergence phenomenon of ketamine, usually you give as a pre-medicant before you give midazolam, give ketamine is benzodiazepines. Benzodiazepines are very effective in decreasing the emergent phenomenon of
Ketamine.
but if benzodiazepines are producing, delirium, that's what I told you, midazolam, when you it can produce delirium for these patients. Then definitely dexmedetomidine is an ideal drug. I still remember when dexmedetomidine was just introduced in India, maybe I think in 2007 or 2008 it was introduced. So one of the babies in our ICU, an infant, actually 2-year-old baby, they were not able to, wean the child. They had to give more and more midazolam. So then actually the pediatricians actually requested our help. So then I, discontinued gradually the midazolam. I started on dexmedetomidine. So after about 48 hours, we could wean the child. Otherwise, almost about 6 days they were trying to wean and they were not able to wean. And just about 24 to 48 hours afterwards, we could wean the child when we switched over to dexmedetomidine for that child. Then it was just introduced in India, so that's how we could use it.
Okay, sir.
One more question.
One more is this. Atipamezole.
Yeah, that is an
Electron.
antagonist. So that is another thing we should have discussed. Atipamezole is a definitive antagonist of the alpha-2 agonists. Atipamezole. Because there is a definitive antagonist is also available, so they can be safely used. Like flumazenil for benzodiazepine, atipamezole for
Dexmed.
thanks for that.
It was Mahal.
Oh, Mahal himself. Okay, thank you, Mahal, for this additional information. Atipamezole, yes, that is an antagonist, alpha-2. Is there any other alpha-2 antagonist that was used for studies in the olden days? When they were using all these alpha-methyl dopa, reserpine, and all those things for just to study their effects on the central nervous system. Any drug? Mahal, you only, said about atipamezole. Any other drug? Yohimbine. Yohimbine is actually an alpha-2 antagonist, not an agonist. So in studies, they were using yohimbine to see what all the effects of alpha-2 drugs to antagonize the effects of alpha-2. So any more questions? Any more doubts?
No, sir.
You have your personal doubts? Any doubts in anesthesia?
No,
This
sir.
will have about 5 minutes. Any doubt you can ask. You need not be the doubt what we have for today's discussion.
The doubt which I had, I asked, sir.
Huh?
The
Suddenly,
doubt which I had,
no, they will have plenty of doubts, but suddenly, if I ask you, you may not cannot be able to recollect that particular doubt. Otherwise, when you are studying every day, you have plenty of doubts, isn't it?
Yes.
Sir, does dexmedetomidine cause cardiac arrest, sir? Arrest, sir?
Can occur, especially because of its effect on bradycardia, the heart rate. So when you combine it with along with these drugs like midazolam, fentanyl, vicuronium, a combination of midazolam, vicuronium, and fentanyl can produce asystole in an occasional patient. So a combination with dexmedetomidine may further can enhance. That is always there, but you have to keep monitoring the patient. So slight bradycardia. What is the heart rate at which you give glycopyrrolate when you use dexmedetomidine?
That comes to less than 40, sir.
Huh?
Like, less than 40.
When do you use atropine or glycopyrrolate? Because when you are using dexmedetomidine, what is the usual advice?
Less than 60 beats
No,
per
less
minute.
than 60 is normal bradycardia.
Less than 40, sir.
Yeah, usually 45. So you can wait till it comes down to 45, and definitely you can give at that this thing.
Yes.
Okay, then we had a very fruitful discussion yesterday and today. So I hope you people are benefited with that.
Yes, sir.
So see, next week and other next week I'll not be there, because next week I don't know whether you people know about 25th and 26th in Mahavir Jain Hospital. They have mainly for exam going students, they have discussions.
Okay, sir.
I'll be, the case discussions are there and machine is there. I'll be discussing on machine. I'll also be discussing on local anesthetics for 2 hours.
Okay, sir.
So the 26th. So next week, so busy, and another next week, and that next week also probably, race also is there.
Yes, sir.
Yes,
People are coming to race.
Yes, sir.
February 7th, 8th, and 9th.
Yes, sir.
I
We'll
think
come in.
I can meet you people physically. Now
Yes,
I'm
sir.
meeting you online. So I think I can meet you people there I'll be there for 3 days.
Yes, sir.
7th, 8th, and 9th. So let us meet there. So
Yes, sir.
tell Mahal regarding when we can have the next discussion regarding inhalation anesthetic agents.
Okay,
Okay,
sir.
sir.
Yes, sir.
Thank you so much.
Thank you, sir. Thank you, sir.
Okay.
Thank you, sir.
Thanks, Mahal, Balaji, Geeta, and Harini for yesterday and today's discussion.
Thank you so much, sir.
Thank you.
Sir.
Thank you.
Okay, bye.